Okay, good morning. We are back and now we are taking a look at some informal testimony around, well, it's formal testimony, but we haven't formally decided to take up the bill, but we've had some questions that have been raised, and sort of this is in the process of whether we're going to decide to take up the bill or not. So we're, and that's on H58, an act relating to Medicaid coverage for play therapy. We are joined this morning by Ashley Berliner, who's the Director of Medicaid Policy at AHS. And thank you so much, Ashley, for joining us this morning. And it's nice to see you in person. We did receive, and I had forwarded to committee members, the definition that you had provided for us about psychotherapy and the inclusion of play therapy. And really, I think the question has arisen from a number of what appear to be, I didn't look at people's licenses, but licensed psychotherapists around the inclusion of play therapy, and they've had some clawbacks about that. And so a fellow representative, raised this issue, and perhaps you could describe a little bit for us the process that, first off, clarifying, I guess, for the record, about the definition of psychotherapy and under what conditions it's billable, by which staff, and how an audit process might happen to request paybacks if the notes aren't written in a way that are acceptable for the definition.
For the record, Ashley Berliner, Director of Medicaid Policy for the Agency of Human Services. Nice to see everyone. So Medicaid does cover play therapy. It's covered as a modality within the broader psychotherapy coverage, and it has to be therapeutically indicated. So that is a big hook to coverage. For Medicaid to cover play therapy as a service, it has to be clinically documented within the session notes on how play therapy is clinically appropriate and how it assists members in meeting their therapeutic goals as outlined in their treatment plan. Our provider manual documents in detail what the requirements are for session notes, progress notes, and it includes documentation of the treatment plan and documentation supporting continued need for services based on medical necessity, including dated progress notes that link to the initial treatment plan, updates or modifications to treatment plan, interventions provided and client response, and start and stop time. Stop there. So that is kind of the burden of the provider to make sure that those notes are documenting the clinical appropriateness and tie back to the treatment manual treatment plan in order for it to be covered as a Medicaid billable service. An audit did occur in 2021, 2022, where a couple of providers were identified as using play therapy without the appropriate documentation. The notes didn't link to treatment goals or the treatment plan, and did analyze the child's play, but didn't put it in the context of therapy and goals. So I don't know, that is our coverage. And when we do audits, we look for things to justify the medical necessity of the service and make sure that it's provided within the context of a covered service. And these two instances, it was not.
So in, I think that one of the questions that has come up is that sort of last part of the definition where it says if non-covered services are provided during therapy, any time spent cannot be included in the total time billed to Vermont Medicaid. And then gives an example about 15 minutes and hypnotherapy or whatever. And that seems to be what psychotherapists have encountered, or at least that's their perception of what they've encountered in sort of the exclusion of what they've documented as part of their therapy notes. And maybe you could describe a little bit. You had told me on the phone that Diva has done some outreach and training or examples of documentation or to professionals in the field around how to appropriately document this service.
So whenever we work with providers around billing discrepancies, we're working really closely with them to make sure that they know what the documentation requirements are. It's clearly outlined in our manual, and there is back and forth to the extent that the provider wants to engage. Oftentimes, or I'll say sometimes, there is no provider engagement and it's not occurring, but certainly state staff are available and work very closely with providers that are willing to make sure that documentation is occurring appropriately.
And so what I heard you say is that the use of things like art or music or play need to be documented in the person's treatment plan about how those modalities assist as part of the therapeutic process in billing for psychotherapy. And I'm presuming you're not a clinician, but do you have examples of what an appropriate clinical note might look like in that? Not with you, but could you provide that? And I have no idea if the psychotherapists that we're hearing from are people who have taken advantage of your technical assistance or question and answer process during or after or during an audit. So I don't know if they've done that and been dissatisfied, or if they haven't done that or didn't know that they could do that in any regard. So there does seem to be sort of a disconnect between what at least some psychotherapists are experiencing and what the definition and process that you outline are, because they have very distinct opinions that, quote unquote, play therapy is not billable. And I recognize that it's not billable as a separate service, that it's a component of psychotherapy. And I think that I'm not exactly sure. So in one case, is there a template? Is there a billing template or something?
Well, there's a provider portal to bill, and
Yeah.
if someone bills on paper claims, yes, there is.
And is there a spot for, well, there's not like a list of things. You're supposed to indicate a procedure code and diagnosis code, I'm presuming, right? Okay. So if somebody only puts down on a note or on a claim play therapy, that's going to be rejected, right?
I believe so, but I can confirm that. That's my understanding.
Because it's not billable as its own service.
Yes, it has to be it has to accompany psychotherapy.
Okay, so and I thinking that there is we're just reviewing. We had received an excerpt from a investigations unit audit, and I guess what I'm wondering is, and maybe I don't know to what extent that we're going to actually have we have a couple of folks who have submitted some information in writing, and then to what extent we're going to have people in person. I think that there's just frankly a disconnect about how to document these services. I think that's the biggest thing. And I know that periodically, in the past, Diva has put out sort of like interpretive memos about how certain things can occur or where there's been questions about certain things. And I'm just wondering to what extent DEVA might be willing to put out an interpretive memo about this topic that could help providers understand how it's included. Because it seems to be a clear disconnect. And if that's possible, then maybe we can do this without having a bill.
I mean, we can definitely get out a provider communication.
Okay. Other questions for Ashley at this point in time? Thank you. We appreciate you being here to kind of, state on the record the things that are allowable under the current Medicaid plan. And it's, while it's beneficial for all different ages, I think, we clearly recognize the importance of this for children, and especially as a EPSDT covered service. So wanting to make sure that kids benefit. And it seems like some kids are, because the psychotherapists have figured out how to do it, and some kids are not because they haven't figured out how to do it. So
I mean, I can, you get a 14-year-old who comes in, the parents want to come in, and you spend 15, 20 minutes playing chess to get his defenses down and so forth. And, I think of that as part of your hour of psychotherapy, but, but if, of course, if it was isolated and said 20 minutes of chess, that would not be.
That would not be right. Or, there could be some section that identifies play therapy in some other state or whatever that, you call it up and you put in that procedure code, and it's like, oh, no, sorry, that's going to get rejected because it's not a separate service here in Vermont.
Right.
Okay. I think that's great, Ashley. If you could follow up with us with a copy of the communication that could go out, that would be wonderful.
Yes, I will get back to you shortly with, if I can, an appropriate clinical note, and then the timing on when we can get
That'd be perfect.
communication out. Okay.
That'd be great. Great. Thank you so much. Appreciate it.
Thank you.
Thank you.
Federal updates.
Yes.
Yeah.
Yeah.
Yeah, I know. As depressing as they are, we appreciate the information.
That's good. Thank you.
All right, so in the interest of covering 4 bills before we hit lunch, we are moving back to S36, an act relating to Medicaid payment for residential substance use disorder and treatment services, which of course is not the crux of why we are continuing discussion on this bill. The continued discussion really has to do with the use of or the request to repeal the provisions that at the end of the bill in section 4 around the use of correctional facilities for individuals who are I can't think of another term, but public inebriate is what it's called.
Right. Yeah.
Yeah, just everybody knows what we're talking about when we talk about that, but I'm sure we'll come up with a better term. So we have Deputy Commissioner Kelly Dougherty back, and it looks like you have Tony with you.
Yes.
Thank you for being back with us. And we are also then going to be hearing from folks from hospitals and the medical profession. And then we'll be hearing from law enforcement and corrections and mental health tomorrow. So we're making our rounds around the Agency of Human Services. So thanks so much, Kelly and Tony, for being with us today. And we started a little bit of the conversation when Kelly was here yesterday, and appreciate any information you have in terms of updated, in terms of the data that we were looking for last week, and really maybe a more complete description of the efforts that are underway with in collaboration with DMH about establishing or strengthening in some cases and reestablishing in others services for people who present themselves with law enforcement usually, as people who are over inebriated. So thank you for being here again this morning.
Sure. For the record, Kelly Doherty, Deputy Commissioner at the Department of Health. And we will actually be joining tomorrow as well to talk in collaboration with DMH around sort of what we're looking at with the mental health crisis beds and PIP. So today, what we were going to do is, because I know there are new members on the committee, was to kind of give an overview of PIP, and I do have some data to share, and I can follow up with more extensive data than what's in the PowerPoint, but this is just kind of to level set and give everybody sort of an understanding of how the PIP system works now, so that you can better understand the repeal question, as well as tomorrow what we're looking at in terms of the PIP mental health merger.
Okay,
So
great.
would you like
I
me
think
to share my?
that'd be great. Thank you. Yes.
So, let me.
Oh, we have a new VDH standard picture. I told Dr. Levine we needed to change up the picture. We'd seen the same one for like 4 years.
Yeah.
Okay, all right. The floor is yours.
Okay, thank you. So I'll just give an overview here of the public inebriate programs as they exist now. So what are they? So they are in statute. You can see the citation there. And it's designed to be an alternative for people who are detained by law enforcement for public intoxication. And so what the PIPs do is they provide an initial screening to determine whether somebody can be managed in a public inebriate program, or whether they need to have medical attention, or if they need to be placed in the custody of the Department of Corrections. So if somebody stays in the PIP program, they monitor the person, and once they are well enough to leave, they are provided referrals to substance use treatment programs and other things. They are voluntary programs, so people can refuse to be served by a PIP, and so there are those things to take into consideration. Anything you would add, Tony?
Kelly, when you say, we can't really see you very well now, so I'm just going to sort of like speak to the screen. When you
Okay.
say in a PIP bed, are you meaning the community-based PIP beds and not the DLC transfers?
Correct.
Okay.
Correct.
Yeah, I think the only thing I want to highlight is it's not just folks who are intoxicated, but the statute really is around those folks who are incapacitated.
Mm-hmm.
Okay.
So the purpose of it is to ensure the safety of themselves and others because of the level of incapacitation they're experiencing. So it's not the average person who might have had too many drinks. It is the person for whom we are worried that if they are not monitored, that something bad will happen to them or to others.
Yes.
And is it usually the case that, either somebody in the community or somebody at a public establishment has called law enforcement? Is that how someone sort of enters this process?
Yeah, it can be a report from others. It can be individuals that are out in the community that are identified, folks walking down the street who fall off into snowbanks, individuals for whom law enforcement is called who are so escalated under their impairment that they take them into protective custody without charge, but to evaluate whether or not the substance is the driving factor for their level of emotional dysregulation.
Okay, thank you. Go ahead, Representative Cole.
Do 211 calls ever lead to connection with the PIP bed or PIP facility area? Because not all of them have beds. But
So I couldn't hear the question.
211 ever a source of referral to a PIP program.
It doesn't tend to be. There may be individuals that a family member might call 211 to say the individual in my home is out of control, but that doesn't tend to be the primary factor.
Representative Donahue.
Yeah, just to follow up along with that, regardless of who might be concerned about a person, can anyone be admitted directly, like a friend bring someone to the PIP bed, or does it have to involve the police having been called and they bring them there?
No, anybody can be brought in. There have been individuals that are that will self-present that they are so impaired, they kind of, for lack of another way to say it, they kind of stagger into the building and kind of, can I get help? Or if a loved one takes them in and says, you know, or just a community member, I found this person incapacitated on the street, don't know what to do with them, can you help?
Thank you. Representative Eastis.
So following along then there, I'm wondering if a person chooses not to stay in the PIP, are referrals made nonetheless to next steps, or is there any conditionality to the voluntary aspect of this?
So I think that's the crux of this conversation, is for those individuals who are either whose behaviors are too unstable to be monitored in a PIP program, or those individuals who refuse. There's no, all we see them is at a point in time. There are attempts to be seen by these folks after their impairment has subsided. That works sometimes and not others. Because it's not necessarily these folks have a substance use problem as much as they may have gone, this could be an event where the college student is so impaired that they may be falling asleep on a snowbank and they are unsafe. Or we actually had a Sentinel event at one point where it was a Middlebury College student who left a program and fell asleep in a snowbank and experienced fatality from hyperexposure.
Okay, I think we should make sure to kind of like move through the other information that you have, because we do have other witnesses too. So thank you. We always have lots of questions.
No, that's great. So this is the current makeup of the PIP locations. So you can see there are only 8 beds currently in the state. And you can see the ones that are with strike through, those programs have closed. And I'll talk a little bit more about that in another slide. But this is where you can find the programs. And I'll just note that there are 2 sites in Newport and in Randolph where they can screen folks, but they don't have a bed to keep them in.
I mean, we heard from the Northeast Kingdom.
Yeah.
We heard from the Northeast Kingdom about their front porch
Yes.
program, and it sounds
Yes.
like they are actually developing a bed.
Yes, they are. So that's a great, that's a fairly new program. And we're working with Northeast Kingdom in collaboration with DMH.
Okay,
They have
great.
had an existing inebriate bed in St. Johnsbury since probably 2018.
Yeah, we didn't hear such good things about that part. I mean, not that the service is bad, but that law enforcement, because again, they might have to, there's probably a 30 to 40 minute wait before somebody could actually get someplace. They opt to take them to the hospital. More often than not, it sounds like. So, okay, let's keep going.
Yep. So here's some data on from FY13 to date. So obviously FY25 is not over yet. So this is partial data for 25. But you can see just in the number of people screened, there's been a very big decrease in utilization of the PIP program. And then you can see the percentages that go into DOC protective custody, the number who stay in a PIP bed, and then other, which could be the person who gets picked up by a family member or a friend, a responsible adult, or it could be somebody who leaves.
Yeah, who's determined not to meet the
Yeah.
statutory requirement for
Yeah.
capacitation. They may be intoxicated, but the determination is that they are safe to self-monitor.
Mhm.
All right, we have a question here, Representative Noyes.
Just a question on this data, looking at how in 2020 it starts to drop off. Can that be attributed to the fact that the beds weren't available or COVID?
They still operated during COVID, but COVID definitely affected the numbers, for sure.
And if you look back, and we didn't add further data back, if you look back to 2010, this has been a consistent drop. 2010, I think the numbers were around 4,500. So even pre-COVID, we experienced a substantial drop during COVID, but even pre-COVID, those numbers have been coming down for the last decade.
Yeah, go ahead, Representative Cole.
Yeah, and I kind of cheated looking ahead at some of the next slides, which I know you'll get to, but it's interesting to compare it to this slide as well. While the number screen has decreased, exponentially, the number of folks sent to corrections in the past 2 years has actually doubled. So it's just an interesting contrast for those folks who were not non-advent reasons of sent to corrections on the next.
That may be a bed. That's
Yeah.
where the bed part plays in.
Yeah, so
Mhm.
So did you say the numbers had doubled at DOC?
they have the numbers of folks who were sent to corrections for non-advent reasons in the past 2 years.
So let's move to the next slide, which
Yeah.
you had started to do.
So this is just a graphical representation of sort of what's on the other slide. So you can just see the precipitous decrease in the number of people who are screened, and then the going to DOC and staying in a PIP bed.
And when you say screened, can you elaborate on who does the screening?
I'll let you do that, Tony.
Yeah, so that's either done by an individual. Oftentimes, it's done by the screeners, the mental health screeners or substance use screeners at designated agencies, preferred providers, or can be done at a hospital. But it's done by a healthcare provider looking at whether or not this individual's level of incapacitation is determined to put them at risk, and then to identify what risk. So really your outcomes at that point are: person could leave alone, the person could leave with a loved one, the person could be referred to a PIP bed. If there's shelter, the individual might be experiencing or suggesting some kind of medical concern where we'd want to have them seen at the emergency department for medical clearance, or their behaviors may be such that they are either refusing or would be unmanageable outside of protective custody.
And so we have another question, but I just have one follow-up to that. So in the places like in Lamoille County at the Howard Center where they've discontinued their the PIP bed, do they still do screenings?
I don't believe Lamoille is doing screenings right now. I do believe that the Howard Center is doing screenings, and some folks are brought to the emergency department for screenings.
Okay, with Representative McGill and then Donahue.
Yeah, I'm just wondering if you have more information on why we have this steep decline in the number being screened. We know use of substances hasn't gone down, so I'm just wondering if you know why. Is it there's less screeners? Is it like different combinations that are popular, the substances that are being used? I'm just wondering if there's an explanation for this trend when we know kind of number of people using substances hasn't really gone down.
Yeah, I don't think we have any great epiphanies of answers. It's been going down for over a decade.
Yeah.
My suspicion is it's a combination of while we still have public intoxication. I think back to my own growing up in Vermont, and I think of the Church Street Marketplace used to have what they called the golf course, where you could go in and get a shot and a beer at 18 different bars and call it the golf club, and you would be sent along your way. So the policy changes that have come forward I think there is a recognition that, again, substance use is a significant concern, whether folks are not getting to the point of that same level of incapacitation, whether there is more permissibility for it, that it, folks are, that law enforcement or others are more permissive of a certain level of substance use in the community, that only the individuals who are most widely seen are the folks that are being picked up, and how much of it is the change of the actual substances themselves.
Yeah.
We just don't know. But I would assume it's a multi-factor answer.
Yeah, never an easy answer. Thank you.
And Representative Donahue has a question.
I had actually the exact same question with a slight overlay to, because it seems to me it would be of some importance for the Department of Health to drill down more into understanding it, because I recall just within the past couple of weeks, there was a major news article reflecting on the severity of the alcohol problem in Vermont, increases and so forth. So that really seems to be a disconnect that I think is worth figuring out, because it didn't sound from that article like, well, we might have a lot of problems, but it's not with severe intoxication. That wasn't the impression that article created.
Right. And there
What
could
made
be
me ask
more.
is about that article.
Yeah. And we know that during COVID, alcohol use, increased. And I think, obviously people were isolated, and there may be more people drinking at home rather than being out in the community. So, but
Maybe they're staying at home more when they get really, but yeah, I don't think we should just hypothesize on that huge change.
mm.
So, thanks.
Mm-hmm. So this is you had asked about bed days when I was there last. So you can see, bed days have also decreased significantly in terms of the percentage utilized.
So
and-
it's the percent of what? Of the total of number of bed days available? Is that what that
Yeah.
is?
Yes,
Okay.
the percentage, the utilization of the beds that were available.
So it seems like we should make some notation when those other beds became unavailable. That would affect that data, I would
Yeah,
imagine.
and that's taken into account in these data
Okay.
when those beds disappeared.
Wow.
Go ahead, Representative Doug. Your last name escaped me for a moment.
Still Bishop. To follow up on this for clarity, I guess if this represents just the utilization of available PIP beds, then the closure of facilities wouldn't impact the percentage, or is this or are these total beds, DOC, PIP, et cetera?
No, this is just PIP beds, and you're right, because those beds were removed and are not accounted for in these data once they were removed, the percentages wouldn't be impacted by losing those beds.
And I guess just an observation that this speaks to some of the challenges we've been talking about with respect to staffing of PIP beds on a 24/7 basis, which is what's probably best practice or best serves the community and law enforcement and others. If you've got only 4% utilization, that's a challenge.
Yeah.
Representative Donahue.
Yeah, so there's a distinction I know from Department of Mental Health hospital beds. So that, for instance, 4% in FY21, just to pick one, that would be 4% of the beds that exist versus 4% of available beds. If you count available, meaning they're staffed and could take someone in, that would be a very different number probably. So I'm assuming this is 4% of the total number of existing beds.
Correct.
So that it could, but the drop to only, because if you take 20% utilization versus 4%, where at the same time, the number of people screened and going into PIP beds was going much lower. That's like a 1,000% drop.
Mm,
But it would make more sense if it was based on available beds. So instead of having, 6 available around the state, there were really only 2 because 4 of them didn't have the staffing to respond at any given
Right.
time. So do you know what that reflects?
No, it's really difficult to drill down to that level. So this is just based on the number of beds in existence.
Okay, thank you.
Mhm. So we worked back starting in 2019, working with DOC and the PIP programs to look at the data and trying to collect uniform data so that we could understand kind of the subset of people that were found to not be appropriate to be held in a PIP program. You can see that these are the reasons why people were taken into protective custody by corrections. And you can see the largest category is behavioral concerns. So other reasons, if there weren't any beds available, like if a program only had 1 bed and it was already full. Transport barriers are when law enforcement can't take them to a PIP program for whatever reason. Maybe they're short-staffed or, they have other reasons why they can't transport the person there. Medical concerns is the least of the folks. And then, like I said, behavioral concerns is the largest reason.
We have another question. Go ahead, Representative.
Yeah, I'm just struggling with kind of the massive data disconnect. 40% in FY '24 went to correctional facilities because there was no bed available, and yet occupancy at the PIP beds was 4%. That's like almost not possible from a data perspective. So I think it may have to do with the difficulty in getting that bed.
Will you say that again,
available.
Ann?
So 40% of the people who ended up in correctional facilities, it was because there were no beds available in FY '24.
Mhm.
But
Representative Donahue, I could probably answer that.
oh, great, okay. But the
Throughout the
4%.
history of time, the Chittenden County and Public Inebriate Services in Chittenden County, the screenings through the Howard Center, have
Yeah.
historically always accounted for between 65 and 70% of all of the assessments done statewide, as well as all of the either PIP admissions or deferrals to incarceration. They just, the size and magnitude of those folks and the amount that was done in Chittenden County was always far exceeded half. So as you start to think about Chittenden County closed, its public inebriate bed, I think that is the largest accounting for, because they always, again, made up more than 50% of the state screens.
So that makes sense then, because there was 0 beds available there.
Right.
Correct.
So bed availability would be, and people are not transported out of their geographic area to a PIP bed.
Right.
Thank you.
Right.
Mhm.
Yeah.
So
Go
this
ahead,
is just
we just have
timeline.
one more question before we
Yep.
move to that one. Oh, I didn't see yours. Okay.
I joined a few minutes late, so my apologies if I missed this point. But is there data on gender of those who are utilizing these services? And what would only women be sent to Chittenden Correctional, and men would only go to facilities, DOC facilities serving men? I'm just trying to think of a transport, or are there just a few beds in each of the DOC facilities and they serve both genders?
Yeah,
Okay.
so the majority of individuals that are screened are male. I don't know the exact percentage. It always had been 80 plus to 20, roughly 20. As far as the lodgings, because folks are not actually incarcerated, they're lodged usually there's usually front kind of, I don't know how to call them, safety cells, but not
Okay.
into the general population. They have, at least historically, and please don't quote me, DOC may have changed their policy, just had folks go to the closest facility. So a male could go to CRCF. They would never be admitted into the general population because they're actually not incarcerated. They're just being lodged for safety until they're able to be released.
And we can get further clarification on that when we hear from DOC tomorrow.
Yeah.
And Representative Cole, and then we'll move on to the last couple of slides.
I can confirm on that one too. When I went to Newport recently in the past year, there was a woman housed in the male facility there in that person. So yeah, but my question is, I want to understand this medical concerns segment. Like, does this mean that the medical concern resulted in the officer saying, "Oh, corrections is the best place for you"?
I was gonna ask
Yeah,
that.
that's
Good, yeah, that wasn't.
Or what?
To
does
ED,
that
right?
mean?
Like the
Elections. Yeah, sorry.
Yeah, we were all having the question of why somebody had medical concerns was transported to a correctional facility.
My assumption is that the screeners identified medical concerns. They were then seen and received medical clearance and were admitted because DOC may have had better capacity to manage somebody than what the shelter bed did or the public inebriate bed did. But ultimately, again, it's DOC's directive and is only to admit what those individuals who have been screened by a community provider.
But that medical concern wasn't like hospital worthy in order to the.
That would be my suspicion, is that, again, because we would have folks who needed to go to the hospital, go to the hospital. If somebody's at imminent risk of seizures, DTs, any of the other, those tended to be in the data, looking at folks who needed a medical clearance was done, and then were placed there because there was at least a better infrastructure if somebody's medical needs became more severe than in the public inebriate bed.
Okay, so that doesn't make sense to us sitting here. I'll just let you know that.
Okay.
I'm just saying, access to hospital is seems to be, I guess. I'm just going to leave it at that. We would have some questions, I guess, further questions about really not what people are presuming, but what the facts are around medical concerns. If there was a medical concern, I would want to know whether those people were actually seen at a hospital prior to them going to a correctional facility, and, being cleared. It doesn't make sense that we would want them to go to a correctional facility if they had ongoing medical concerns. So it's just questions about what that data point really means.
Yep, we can look into that.
I know, we have the hospitals coming next, so. Okay, thank you.
This is just a timeline of when the programs that closed. So you can see that. And the challenges. So we talked about staffing. Hiring and maintaining staff in these programs has been a challenge across all of the programs. They utilize an on-call model. So like staff would receive, a stipend or something for being on call, and they would get paid, for the hours that they spend responding to a call or coming into the program. And it's just such an unpredictable demand for the services that it really wasn't sustainable for staff to be working under that arrangement. The decrease in utilization made it difficult for programs. Like they would have to maintain their capacity regardless of the level of utilization. And then the cost, having this standalone, 24/7 program, it's more successful. So you can look at like our Rutland program is co-located with a residential treatment provider. And so that seems to work better because they already have 24/7 infrastructure in place. Whereas these other standalone PIPs was really difficult to maintain that staffing.
Yeah, we heard that from Northeast Kingdom Human Services last week
Yeah.
as well, that
Yeah.
in this day and age, it almost is a requirement that it needs to be co-located with another program. So,
Yeah.
and we'll hear more about that tomorrow. So, okay, thank you both very much. This has been really helpful to understand the background and sort of the history of these and some of the data around them. So it will help us in making decisions about what to do with these two sentences at the end of the bill. Go ahead, Representative McGuire has a question.
Thank you very much. Just a quick question or a request. By any chance, is the data, PIP, bed utilization, and screening, by any chance, could we get data broken down by day of the week?
We have historically done some dives into it. I mean, it was as expected Thursday night, Friday night, Saturday night had always been higher.
That's
Let
what
me
I'm
look
going with.
Yeah.
Because if
Yeah.
we're collecting data based upon a 7-day week, we are, from your example,
Yeah.
we know when the majority of screenings and bed utilization is utilized. And
Yeah.
I think it'd be very, very important to see that data.
Yeah.
Yep.
Okay, thank you.
Thank you.
Thank you.
All right.
Okay, we're going to move on to our next witnesses from Allison? No,
Allison's online.
she's online. Okay, so are you Elizabeth? Okay, great. Does it matter which one of you goes first? Allison? Okay, Allison, you're up next. Good morning. And neither you or Elizabeth have been here before, I don't think. So we're just going to do a quick round of introductions. So you know, one, especially since you're on Zoom, who's in the room and who you're speaking with. And thank you both for being here. My name is Teresa Wood and I live in Waterbury and I also represent Bolton, Buellscore, and Huntington.
Ann Donahue from Northfield and also represent Berlin.
Good morning, I'm Dan Noyes. I represent Wolcott, Hyde Park, Johnson, and Belvedere.
Brenda Steady, East Milton, Westford.
Doug Bishop, and I represent Colchester's Chittenden 20 District.
Good morning, Todd Nielsen. I represent Brandon Forestdale.
Hello, I'm Zon Eastis. I live in Guilford and also represent Vernon.
I'm Esme Cole of Hartford.
I am Jubilee McGill from Bridport and also represent Middlebury, New Haven, and Weybridge.
I am Ray Garofano. I live in Essex and I also represent Essex Junction.
Hi, I'm Lori. And this is
Hanging in there. Okay, go ahead. We just do introductions. So just say your name and what town you live in.
I'm Hunter. I live in Virgins.
I'm Devin Green. I'm with the Vermont Association of Hospitals and Health Systems.
Liz Kudo, I'm with the Emergency Nurse Association, and I live in Morrisville.
Amy Johnson, Vermont Care Partners.
Jessica Shabana, Policy Director, Department of Health. Catherine McNabb, I'm an intern for Representative Donahue, and I go to Norwich University in Northfield. Meg Phillips, Action Circles, I represent the County Province of Vermont.
And a number of clients as well. And yes, I'll come with that. That's all right. And Representative McGuire.
Hi, good morning, Representative Eric McGuire, Rutland City.
Thank you. And Ms. Davis, the floor is yours to introduce yourself and give us your thoughts about this bill.
Thanks so much for the opportunity to speak with you today. So again, my name is Allison Davis. I'm the medical director of the emergency department in Rutland. So I already knew Eric. I've testified before for both the House and the Senate on the issue of workplace violence in our hospitals and the need to protect healthcare workers from mental and physical harm. So I just wanted to share a couple of thoughts this morning, but of course I'm happy to answer questions about our perspective on the public inebriate program from the perspective of the EDs. But over the past couple of years, since the last time I testified, our hospitals, I know, have all been working very hard to protect staff. In Rutland, we have enhanced security coverage. We've introduced a metal detector in our ED entrance and we began searching patient belongings for weapons prior to admission. We've revamped the training that we provide to staff in terms of de-escalation and safe restraint techniques. But despite all of this work, our staff and sometimes even other patients continue to be struck, spit on, shoved, and verbally assaulted. Agitated and uncooperative, intoxicated individuals without any medical needs are a danger to staff, and they prevent us from caring for your loved ones. If the police have determined that these individuals are unsafe to be out in the community, the police should still have that option to keep them warm and dry for the hours it will take for them to regain capacity. If the only option that you give police is to bring these individuals to the ED, you will be endangering our staff and other patients. If not repealed, this statute will add to healthcare costs at a time that we are all trying to control them. And it also sends a message to healthcare workers that their safety is not a priority. The simple threat of this statute going into effect has already caused anxiety and fear for healthcare staff in the ED, which is why I'm here today. So our local police are vital partners in the work to keep our staff and our patients safe. This allows the ED to fulfill its mission of caring for patients who are having medical and psychiatric emergencies. We have been fortunate in Rutland to have one of the few remaining functional public inebriate programs. Last year, Grace House cared for almost 200 individuals who did not require any medical attention. Most of the time, intoxication is simply intoxication. And the PIP is an example of right care, right place, right time. So I'm here today to answer questions, but also to ask for your help in protecting the front lines in our work to care for our communities by repealing the statute and its effects on the PIP program.
Thank you, Dr. Davis. Also, it seemed as though you had some prepared comments. It would be great if you would send them in to Lori Morse after we're done here.
Sure.
And I think I saw, did I see Representative Cole, a question from you?
I was thinking about it, but.
Okay. You don't,
Maybe I'll get to it later.
Okay, all righty.
Thank you.
So, Dr. Davis, we certainly have seen at least a couple of different bills in the last few years around workplace safety for healthcare professionals and understanding the differing circumstances that you are encountering than, just a few short years ago, and how that is impacting the changes that, you just talked about in your emergency department and other hospitals around the state. Could you describe a little bit the process as you see it from your perspective when a law enforcement officer brings in a person who, seems to be lacking control of themselves or, is a potential threat to themselves or other people. What happens when somebody comes in and let's just say they brought them to the hospital for screening and they haven't been to a designated agency prior to that process? Can you just describe a little bit about what happens on your end?
So, if the patient is complaining of something, chest pain, trouble breathing, an injury, they get assessed the same way that any other patient would get assessed. And once we've determined if there's a medical concern that needs to be addressed, or if, as an example, if the patient says that they're suicidal, we care for the patient until they have capacity and either can be discharged or in the case of somebody with complaining of I mean, I'm just using suicidality as an example, they would then get screened by the designated agency once they are clinically sober and can participate in that conversation. So it would be the only instances really, I think, where from an RED, they would go from the emergency department to correctionals is either if they are in the custody of corrections for another reason, they've been cited for a criminal event, or if they are so uncooperative, and they get to the ED and they do not want to be cared for in the ED, then we would medically screen them the way that we would medically screen anyone to figure out if there is any kind of emergency condition that would require our attention. And then if they don't want to be cared for, we would let corrections take them to wherever their next step is.
So do law enforcement typically wait in the ED for somebody to be assessed? Or let's just say if a person, in the end, the assessment reveals that there is no medical reason for them to stay at the hospital, is law enforcement staying around, or do you have to call them back, or do you just release the person?
So it depends a little bit on the scenario. If we ask them to stick around because we were concerned, then, they're usually are willing to do that. But typically they would not stick around unless they had to, because the patient was in custody for another reason.
And if somebody is brought to the ED, is it sort of common practice for you to call upon? So, just use Rutland Mental Health in this circumstance. Is it common practice for you to call on the emergency screeners at Rutland Mental Health? Or is that dependent upon what you determine after your initial assessment?
So if they're asking for, if there's a reason to believe that they are having a psychiatric emergency that would get the designated agency involved, like saying that they're suicidal or if they're psychotic. But typically we wouldn't call Rutland Mental Health otherwise. We would call Turning Point and have peer recovery coaches come in and talk to the patient about treatment options. But the designated agency would only get involved if we thought there was, they needed a psychiatric screening.
Thank you. Other questions for Dr. Davis? Yes, go ahead, Representative Bishop.
Just to follow up on the last thing that you said, just so I have a clear understanding, if there is no psychiatric issue, there's no medical issue, or the medical issue is simple and is treated and the police have gone, in all cases, are there referrals to Turning Point for peer interaction, or are sometimes individuals simply released?
So Turning Point is an opt-out program in our emergency department, meaning that we will call them for all patients who present with any type of substance use concern. Patients can refuse to engage with them once they arrive. And so in that case, we would release them. But for the most part, they establish a very good rapport with patients.
Thank you.
Thank you. Thank you, Dr. Davis. We appreciate you being here, especially given I'm sure you have a pretty hectic schedule. So thank you so much.
All right. Thank you.
Okay, Liz, welcome to House Human Services. You get to sit at the head of the table.
Thank you for having me. I really appreciate the opportunity to be here and speak with all of you. As I already mentioned, I'm Liz Kudo. I represent the Emergency Nurse Association. I'm one of the directors for the state, as well as I have the chair for government affairs. I actually got into that out of my own interest of trying to protect the quality of care that we've all been trying to give against all odds in emergency departments across not only the state, but the nation. And this has been a great platform to understand how we can work together to do that. I've been in emergency medicine for 17 years across multiple states and in a couple of hospitals here in Vermont. So it's given me a great perspective of inner city, community hospital, trauma centers, level 1 to 4. And it's really helped me get to hear, and again, how we can work together to move forward with healthcare. Emergency department overcrowding causes multiple problems for patients, as we mentioned, and staff. So increased wait times, increased medical errors, increased length of stay, increased patient mortality, increased risk of workplace violence, increased burnout with high turnover rate, increased harm to hospitals due to financial losses. That's no new news to anyone here, I don't think. Unfortunately, also, and according to the Bureau of Labor Statistics, the healthcare and social service industries experience a high rate of injuries caused by workplace violence and are 5 times more likely to suffer violence injury than workers in any other precinct. 5 times. 5 times more than a police officer who is trained and armed. And we're just there to try to help provide quality care to the individuals that need it. All individuals, vulnerable populations as well. Vermont is now leading the nation with the highest rate of individuals away from work due to workplace violence. So this is what kind of curtailed me into ending up here and working with a coalition of nursing around trying to standardize workplace security violence programs across the state. So I was really impressed to hear the security that Rutland has. That is not a standard that is supported or regulated across the state. And the risks to all of us remain the same. So we're currently working, as some of you might have heard, on a bill 259 in regards to doing that. We're really excited. However, as I stumbled upon reading through other things, I was reading about S36, and it quite frankly, I've lost a lot of sleep over it. And I think anyone in our field who I have this conversation with, who realize kind of where best intentions from one end to where it's going to be implemented, have realized that there's a major gap in what's going to happen with this. And therefore, I'm really here to talk about how we really need to, we are requesting that this be repealed with the attempts to look at what is going to be a better option for these individuals. Forcing an additional population of high-risk, vulnerable patients into emergency departments will not only exponentially increase risk for all patients needing care, but could push hospitals past their breaking points. I actually personally don't see how emergency departments are going to survive this. Emergency departments are not the place for inebriated individuals that do not have a medical exam need. I'm more than happy to field lots of questions about that. I love these conversations because, again, there are patients that need screening. We are there to do that. They have complex situations. We want to help them. But the individuals that are just requiring detoxification do not belong in the emergency department. In addition, we don't provide appropriate care for them. They are high risk for injury to themselves because of their inability to remain safe. They are high risk to the workers that we are trying to keep them safe, where unfortunately most of the times they're unable to make safe decisions about what we're trying to do for them. And they're at risk for the hospital, the providers taking the liability to try to care for them, as well as the resources and financial resources to care for them for extended periods of time when they're in our care. If they're under the influence, we can't let them leave unless there is a safe plan. So by putting them in the emergency department, rather than putting them to the Department of Corrections, we then will have them in our care for hours, 8 hours, 16 hours, 24 hours, depending on what their blood alcohol level is. So that extended time period of having a patient, because we cannot medically clear them safely to a safe disposition, is only going to, like I said, further all of those problems for patients and workers. We need appropriate sustainable strategies to ensure safety for all patients and staff, especially these vulnerable populations. As we all just heard and talked, the PIP beds are going away. I'm currently in Lamoille County. We do not have PIP beds. So we do not have the option of detox. And the idea that As we saw, 40 to 50% of them are going into protective custody. 40 to 50% of them coming to emergency departments is unsustainable. So again, you know, directing the industry that has the highest rate of workplace violence, directing these individuals at us is kicking the can down the road, but it's actually just kicking the can directly at us. And we need essentially this to be a better discussion around how we can support these PIP beds, the staff that want to be here to take care of people, as we just talked about how it's hard to keep staff because of this cycle, but not by furthering where these individuals are left to go, and requesting that S36 be fully repealed.
Thank you. I think it's obviously sobering statistics, and I appreciate your citations because oftentimes people provide testimony and they don't provide citations, so I appreciate that. One of the questions for me, as you were talking, so it's my understanding, at least, and somebody from VDH or DMH can correct me if I'm wrong, but that there's a requirement that a person be assessed. And so whether it's at a designated agency or whether it's at an emergency room, or I don't know, there might be another third place, substance use provider, I suppose, that's not a designated agency. I'm just trying to understand the process a little bit better, because it feels to me like you're seeing these people already, because the hospitals are the assessment point in some cases, like if there's not an assessment available in the community, like through a designated agency or other preferred provider. So because there's a requirement for an assessment prior to somebody being taken to corrections, even if it's only an intoxication without an other medical issue. Is that not your experience, or?
I think that this is very gray. I think it's also very county and organization related. I think that some of the PIP beds, and again, I can speak to the 2 PIP beds, unfortunately, both which have closed associated with the hospitals that I've worked at. A lot of them would come in for screening and medical clearance and then go directly to the PIP bed. The other organization had healthcare providers that would do the screening at the PIP facility. And then if they deemed that they were not safe or needed further medical attention, would then bring us to the ER. We occasionally get some from the police who come and say, you know, we were just concerned, we found this individual, not really sure. We provide an EMTALA screening. Is there anything, medically necessary that we need to emergently address right now? No. And then in that case, they would then be discharged to the corrections. We don't see all of them that are coming in from the community that are just inebriated. I don't know if there's a screening process at the Department of Corrections, depending on, again, which one they go to. I think they might all have different processes, as well as the fact that a lot of organizations, police departments also have embedded techs in their organization. So I think they've been helping to serve as that in regards to, do they need further medical screening? Or is this just an inebriated individual that can then go to corrections? So I wish it was black and white. It would make it a lot easier for all of us, but I think everyone's using the resources that they have to make the best of the situation currently.
Yeah, and I think that's probably part of our concern, is that it varies depending upon your location. And so it doesn't quite feel right that you might end up in corrections because you happen to live in a county that doesn't have the resources and the community-based resources, whether it's, a community hospital or a designated agency with a PIP bed or screening services. So, and we're talking with sort of all the relevant departments tomorrow to see how they're working on trying to rectify that across the state. So, Representative.
Yeah, and just to add on to that, it wouldn't be right for someone to end up in corrections that would be better suited elsewhere. It's just as not right for them to end up in the hospital when they shouldn't be necessarily in the hospital for that reason. So I think our aim, at least my understanding of our aim, is what is the correct avenue that after, if resources can be allocated in some shape or form to that screening for the appropriate place, which may not be either of the 2. Like, can we have that happy medium? Because it's absolutely correct. I mean, I, friends in the ED as well doing the intake for like the mental health crisis, especially. It's just like, I cannot believe what you guys go through. It's so hard. And that is not at all, I think at the end of the day, that will not be implemented in the language of the bill to increase hospital intake. But I totally understand that is not where we want to go. And I don't think as legislators, we want to go there. And we know you don't want to go there.
Well, I think that's what's concerning, because the way it is written, it reads, that these individuals
it's
will
just-
hit, but
Yeah.
as we just saw with the statistics, and as we know as my hospital right now, there are no PIPs and they're going
Yeah,
away.
Exactly.
And they're not sustained, and therefore now they're just gonna go to the emergency
Yeah.
department. So, correct, I appreciate that. Our job is challenging, but we're here to take care of patients. The problem is that the individual is having a heart attack in a hallway bed that we're trying to care for, in addition to everyone else that is just boarding and waiting for all of the other issues, as we continue to add these additional communities and types of patients into our community that really need the outpatient resources sustained. It's going to break us.
Thank you. Other questions? Thank you so much. We really appreciate you and Dr. Davis being here to put an exclamation point on what's happening or what you don't want to see happen in our emergency rooms, or happen any more than it already is, for sure. And thank you really for the work that you both are doing. Appreciate that.
Thank you.
Okay, folks, we will see you back after lunch, at which time, guess what? We're going to be taking up H92 again.
After